Okay, welcome. For those who are rejoining us, welcome back. For those who are joining us for the first time, welcome to our final plenary session here for our AHA ERC Guideline Release event. And this is the Hot Topics presentation where we're going to get the hottest highlights from each one of the areas of resuscitation where we have new guidelines being published. But before we start with that, we want to do a little bit of acknowledgement for all the volunteer work that was required to make this happen. So for those of you here in the room, I would like all the writing group chairs and co-chairs to stand up. Writing group chairs and co-chairs. Round of applause. Stay standing, stay standing. In addition, all the writing group members, anyone who was on one of the writing groups as well. This is both ILCOR, ERC, AHA, keep standing. And then anyone else who contributed to the evidence evaluation for the guidelines, stand up. That's incredible. Okay, thank you so much. And just wanted to highlight the fact that this is an incredible amount of work, which with a huge workforce of dedicated volunteers is the only way that this can be done, and that's how it makes it happen. So thank you again. So we are ready to proceed. We're going to jump right into the Hot Topics presentation, and then we're going to start with our first presentation from BLS.
Thanks very much. So the observant among you, if you've looked at the agenda, will note that I'm supposed to be Janet Bray. Clearly I'm not. I wish her well, but my name is Mike Smythe. I am the Vice Chair of the BLS Task Force, hence why I'm here on behalf of Janet, but I'm also the Science Chair for the ERC BLS Science and Education Committee. So we started off with our launch event. And this is the summary of the things that we went through. So, like some of the earlier plenary session, we had a very brief overview of the evidence appraisal and guideline development process, so that people who were following us online had an understanding of what we were doing. We looked at the difference between the AHA and ERC algorithms, and my sincere apologies to the AHA. I used the wrong algorithm. I had an outdated algorithm, so it created a little bit of fuss, but actually when we were in the room, we got a long time to focus on the AHA algorithm afterwards. We looked at the primary differences between our two guidelines. The areas that took particular amount of discussion were the notion of how we recognize cardiac arrest. It's slightly different in terms of how AHA and the ERC approach that. We looked at the EMS activation process. There's a step change for the ERC in this regard. So historically, we were with a patient who is unresponsive and not breathing normally to then call for the emergency services. Now we've migrated to, if somebody is unresponsive, call and then assess for breathing. So it's a step change for us. So it's slightly different. We did have a discussion about firm surface CPR. Despite the fact that we were both referring to the same evidence and we both had the same understanding, there was a slight difference in terms of emphasis, in terms of how we should approach managing the patient who's on the bed versus on the floor. And then we spent quite a bit of time actually addressing foreign body airway obstruction, because there's quite a lot of there's a lot published, but there's not an awful lot of evidence about how we manage those scenarios. We also looked at areas where we have had new additions to the guideline, or we've got increased evidence to add to why we do things. In particular, we looked at pad positioning. So we recognize across both organizations that the lateral pad, so the apical pad laterally is often poorly placed. So we've got increased emphasis in terms of where to go by use of diagrams. We've looked, both guidelines address how to apply defib pads in the event that the patient is wearing a bra, how we make sure that we've got good contact, and we looked at CPR in obese patients where the evidence suggests that maybe there are no appropriate adjustments that we can recommend, and that we stick with the current sort of CPR regimes. We also identified that there are a number of research gaps. In particular, we note that there is a lack of good information about ultra-portable AEDs. Whilst we know that they are being marketed, we don't really know about efficacy yet and the number of shocks that they can deliver. the pad size and where they are placed in terms of the initial defibrillation, whether or not we should be going anterior lateral, anterior posterior, and in particular, there seems to be growing interest in the use of foreign body airway removal devices, but we don't have any good clinical evidence for that, and that's a particular area where we need to see improvement in the available evidence to help us build better guidelines. Ooh, that's gone back. Sorry, I pressed the wrong way. So that's the summary from BLS. I'll hand over to Ian.
Thanks, Mike. Hello, everyone. My name is Ian Drennan. I am the current chair for the ALS ILCOR task force and had the privilege of moderating our ALS and PCAC session, post-arrest care, which went excellent. I would encourage people to go find that podcast and that audio when it becomes available. So what I'll do is I'll just give you a brief summary of some of the things that we had covered in our webinar session. There were lots of really exciting updates from the ALS chapter. But overall, what we felt was, I've really screwed this up. Let's try again. Overall, we felt that the AHA and ERC guidelines were actually very similar at some of those core issues in terms of the ALS care. And where things were a little bit different was just around some nuance around some of the interpretation of the literature that was available. So when we looked at the actual, when we looked at the algorithms have both been updated, but again, kind of those core functional pieces within each algorithm were maintained the same between both groups. Some of the key areas that we covered. So in our session, we were talking about ALS care and starting ALS care early on in the resuscitation. We talked about early defibrillation for shockable rhythms, and we talked about early CPR and adrenaline or epinephrine for non-shockable rhythms. So a couple of the controversial areas around there that we had discussed a little bit more was around when you should maybe give that first dose of epinephrine in shockable cardiac rhythms. So the ERC says after 3 shocks, AHA says after 2 shocks. The idea for both groups being that there may be a little bit of harm in shockable rhythms if you go ahead and just give adrenaline or epinephrine to those patients. And so try some of the other things that we know work, like defibrillation, and see if you can get a ROSC back with that before you move on to something like epinephrine. So in non-shockable rhythms, there was good consensus that early epinephrine is probably beneficial in those patients, but to potentially delay a little bit on the shockable side and see if some of those other treatments might work a little bit better. There was a lot of discussion around ventilation. Of course, we got to continue doing high-quality CPR, but included in high-quality CPR now, there's an increased recognition of the importance of ventilation and making sure that we're doing appropriate ventilation, and that if you ventilate too little, you ventilate too much, both of those things are probably associated with something bad happening. What that is, what it is to hypo and hyperventilate, we're not quite sure. We need some more research in that area, but making sure that you're focused in on those ventilations, and there's some good research out there now that suggests that the ventilations we provided in the pre-hospital setting and probably in hospital setting when we're not focused on them may not be up to standard. And so we had a good discussion around the kind of increased emphasis again on ventilations. The correctable reversible causes we discussed. Both groups assure me that there's actually the same, even though there's one H and one T missing from the ERC guidelines. They tell me they've just reorganized them a little bit. So there is the same amount of reversible causes depending on which side of the ocean you're on. They're still there. They're just done a bit differently. We had a good conversation around advanced airway management, and both groups were consistent in their determination that if you're going to intubate people in cardiac arrest, you need to make sure your expertise and you're highly proficient at doing that intubation. And that the ERC side, they've put some numbers behind that, saying your first pass success should be over 95%. The AHA side, it was a little bit less. There was no direct numbers, but the thought was still there that if you're going to intubate people, you need to make sure that you're able to do it proficiently and not take lots of time off the chest to do so. And if that's not something that is capable for a variety of reasons within the system you work, that you should move to something like a supraglottic airway or use BVM ventilation. Along with that, and making sure that your intubation attempts are successful, we had a lot of discussion around end-tidal CO2 and the use of end-tidal CO2. Again, from both groups, strong recommendations, and on the ERC side, that you must use continuous waveform capnography if you're going to intubate people in the field or in the hospital, right? So discussion around end-tidal CO2 for intubation. We also had some discussion around targets for CPR quality. Both groups ending somewhere around end-tidals of 20 to 25. There was a slight discrepancy in there in terms of what you should aim for if you're trying to do CPR. And if you're not trying to do CPR, if you're doing CPR and trying to do good CPR, and then if you're not at 20 to 25, how do you fix that, right? So it's fine to say, hey, I'm not quite there, but you need to be able to do something about it. And so we had a good discussion around whether you fix your rate or depth. Depth was the one that came to the forefront as being a really important one, whether it's hand placement, those types of things. And so making sure that we're doing something to fix that end-tidal CO2. The other things we discussed, so we had a lot of discussion around double sequential defibrillation and vector change defibrillation, both groups coming up with some wording around not recommending or needing more data to look at the use of double sequential defibrillation as a defibrillation strategy. And on top of that, regardless of the guideline recommendations, ensuring that your initial defibrillation strategies are optimized, right? So making sure that your pad placements are appropriate, your pad conductivity is appropriate, making sure you're doing a good job with your initial defibrillation attempts before you even consider whether or not you should be moving pads around or not. And so the current recommendations on both sides are not to do double sequential defibrillation until we see some more data and some more research behind that. The last thing we had a good discussion around was all of these kind of tertiary or secondary type drugs, and there's a lot of them. Most of them, the recommendations are don't give them. So things like bicarb, although our expert panel suggested that we need a lot more higher quality evidence in this area around bicarb administration. Currently, what we know about bicarb is that there's nothing that suggests it is effective, and so not to give bicarb routinely in your cardiac arrests, but an area for further evidence evaluation. Same thing with calcium. We have some strong evidence that calcium is ineffective in cardiac arrest management, and steroids, kind of the same thing. So those were kind of the three big ones we talked about in our session as well. And I think that's it. I'll pass it off. Thank you.
Afternoon, everyone. My name's Jason Ackworth. I'm a paediatric emergency physician from Australia and the current vice chair of the ILCOR Pediatric Life Support Task Force. In our session this afternoon, we focused on a series of topics within the paediatric basic life support area that we thought were either new updates or where there were certainly some major differences between the guidelines set from the AHA and AAP and the ERC guidelines. So we picked 6 topics. Some of them turned out to be more controversial than others. The first one we talked about was recognition and call for help. And really, with each topic, we had a look at what the differences were and saw why things do it. There's some subtle differences on this, and this really came down to how much we used pulse check, and certainly there's a de-emphasis of pulse check in each of the sides of the ocean in doing these things. But certainly there was still a lot more use of the allowance for pulse check in the American guidelines. The sequence of resuscitation, major difference here was really around whether you started with rescue breaths, which are still in the ERC guidelines, whereas in the AHA and AAP guidelines, starting with compressions for these. The compression to ventilation ratio, the same for both sides of the ocean, but there was a difference here based on the ERC had chosen to make differences in this based on the training of the rescuer, whereas the AHA and AAP had another nuance to that it depended on the number of rescuers there. So there's still a difference there whether it's 1 versus 2 rescuers. Then we got into infant chest compression technique. This was an interesting one. Both sets of guidelines have moved away completely from the 2-finger chest compression technique, showing the clear advantages of the 2-thumb encircling technique. But there were some subtle differences around the alternate instead being a heel of one hand. Interestingly, when we had the discussions, we found that despite there being the everyone was agreed on the two thumb encircling technique. The position of the thumbs caused some controversy, whether they're on top of each other, across, next to each other, yeah. And the differences in the pictures that actually been generated by both sides. Then this flowed on to foreign body obstruction in infants. We really focused here on the chest thrust technique in infants. I know there are some other differences. And this then came down to, despite both groups talking in chest compression techniques, looking at the two thumb technique, in this one, the chest thrusts, one side looked at the thumb encircling technique as the preferred method, so a movement away from using the two fingers, thumb encircling technique, whereas it was the American side that used the heel of the hand as the preferred technique for providing the chest thrust there. It became clear that that came down to just some practical implications of how you move the child around and put your hands in there. And then defibrillation pad placement. The big change here is that in both sets of guidelines, we are saying AP position preferred for paediatrics. However, that was where the commonality finished, and there were some differences then just on placement of pads, orientation of pads, and to be truthful, some of the things we didn't realise there was a difference until we saw the pictures. When it really came down to looking at things, I think the summation of all of the discussions that we had, we suddenly realised that despite working from the same evidence synthesis, that is the ILCOR group and some of the work they did, different council guidelines, there's differences in the council guidelines and they remain. But we all agreed that there were fewer differences than there had been in previous iterations of these guidelines. And why are there still differences? I think where the evidence is indistinct, and certainly in paediatrics, we suffer from a dearth of evidence in a lot of these areas, and the councils are trying to provide a practical way to fill in those gaps in the research. And they do that by discussions. And can I say, in general, when we quizzed them on why there were the differences, it seemed to be that for all of these, they were based on discussions that are generally both logical and sensible. So from the same evidence, they were coming up with slightly different nuanced approaches. Both sides seem to be reasonable. We did ask our teams what the gaps in the research might be, and really those came down to filling in lots more evidence for a lot of these techniques that we're looking for, the issues of practically where everybody agreed that ventilations are important in paediatric resuscitation, but really some of those subtle things, whether we start with the compressions first, or the ventilations, knowing that there's very little difference with what we have so far. And a big call for some of those more evidence on those foreign body airway obstruction devices. Thank you very much.
Hello everybody, so my name is Barney Schofield. I am the chair of the ILCOR Pediatric Life Support Task Force. I'm a paediatric intensivist from the Hospital for Sick Children in Toronto, and I had the privilege of moderating, perhaps with my ILCOR hat on for one, but also the fact that I'd spent 20 plus years running the ERC Guidelines in the UK and now moved over to the North American system and had to navigate resuscitations under the AHA and now the AAP AHA guidelines. But the hot topics and the kind of, controversies similar to what Jason had presented weren't that many. What was really good is the combined kind of alignment to both from the evidence to the two resuscitation councils and the groups to actually see eye to eye and to be delivering very similar kind of advice within the guidelines to their members. On the left, you will see the two now unified chain of survival, which is across both pediatrics and adults. What is great is that both the writing group members from each organization managed to squeeze in as many pediatric emphasized elements within that, the kind of emphasizing rescue and ventilation breaths and kind of ventilation within that. On the right-hand side, you'll see a summary of some of the big things that we talked about, similar to the adult group. the kind of emphasis that if you're going to move towards intubation, it should be a skilled, competent survivor. And we discussed the elements of training, and if not, then bag valve, mask, ventilation, or a supraglottic airway. The avoidance of hyperventilation and that use of end-tidal CO2. So similar kind of emphasis to the ALS adult group. Perhaps one difference which still remains is about the first shock dosing within the pediatric guidelines. The AHA AAP guidelines still suggest 2 joules per kilo as the first shock. On the ERC guide, 4 joules per kilo. But on the AHA side, that too goes up to 4 after the first shock if unsuccessful, with then higher ceilings of increased dosing as you proceed through the resuscitation. And similar to Jason, the reasons for those differences under the same kind of level of evidence that had been generated were to do with kind of contextual implementation processes that are developed within the two systems. But again, more research on exactly which one is better and which one can be generated remain. But the emphasis on early adrenaline or epinephrine within the non-shockable rhythms remain. It was exciting to see that within the quality of CPR, particularly for patients that have invasive blood pressure monitoring, we now have targets that both groups decide upon for both infants under the age of 1. Diastolic blood pressure targets are 25 millimeters of mercury within when you're giving chest compressions at target, or 30 millimeters of mercury for children. And that's a real kind of step forward within the evidence base for children. And there was lots of discussion about post-resuscitation care as well as these targets to avoid hypotension, and we have targets to try and maintain a blood pressure above the 10th centile for either systolic or mean blood pressure, which were changes, but again, aligned across both the ERC and the American guidelines. So there are unified priorities. As I mentioned, implementation and how these guidelines get out there and how the algorithms are used are important, but the message is very clear: focused monitoring and improvement across that. There are now in both sets of guidelines really big messages around both the neuroprognostication evidence and how to use that, both for the use of trying to get good prognostication markers as well as those to identify patients who may be heading to an unfavorable outcome. But with some caveats. So multimodal monitoring is essential. The guidelines do give some guidance now to clinicians which kind of those tests in that post-arrest period are more accurate, and also which ones aren't and probably shouldn't be relied upon within the setting of both decision-making, conversations with family, and future care. However, survivorship remains a huge thing in the pediatric world. The life that these children are going to have can be long. The quality of the life remains essential within that. And the shared research agenda, similar to all of my groups, we need more research in the pediatric world. We call out to the organizations and the funders and the decision makers to put more research available so that we can have much more firm evidence, so that we can be confident, and whether that's further hemodirected CPR, the airway management, timing, defibrillation, and of course, to ensure that the children that we're resuscitating have a future to live for. Thank you very much. And I think I invite all the gentlemen to leave the stage so that it can be filled up.
Hi, everybody. G'day. I'm Helen Liley from Brisbane, Australia, Chair of the Neonatal Life Support Task Force, and I've just had the privilege of chairing the comparison and alignment of the AHA, AAP and ERC Neonatal Resuscitation Guidelines. I've been asked by a couple of my colleagues to be a bit provocative and point out that the order of our presentations has been completely backwards, because it does all start with birth, Or actually, we get even more fortunate than that in the neonatal world because fetal life is increasingly understood, and the opportunity for anticipation and prevention of the need for resuscitation does not actually start at birth, but before that. In addition, we get to practice the most fascinating type of resuscitation because our patients are undergoing the biggest physiological transition that happens at any time of life, that the transition from fetal to neonatal life, during which pretty much every organ and tissue in the body changes the way that it functions. And it's against this background of rapid change over the first minutes after birth that we get to think through the processes of resuscitation. Another phenomenon is that that the day of your life on which you're most likely to need some form of resuscitation is actually the day that you're born. And you only have to go back half a century or so before neonatal resuscitation was in its current form and look at the very high perinatal mortality rates at that time to realise how far we've come. So we had a lively discussion in the session on the neonatal guidelines, discussing some of the controversies and differences. Perhaps the most important thing to point out is that, as with all the other presenters, the guidelines on the different sides of the Atlantic are far more concordant than they are different and are largely based in the same available evidence. But where there are differences, they're most often in areas where the evidence is insufficient and where we really need to promote the collection of new evidence, new trials, new observational studies that will help answer those questions. The main differences concern education and implementation, but at the same time, and also many of the two sets of guidelines are based in their own familiar formats and organisational requirements, which do have some differences in the different locations. There are some differences in gestation thresholds that have been used. We also, the smallest of our patients weigh less than half a kilo, the biggest more than 5 kilos, but changing gestation also changes physiology and vulnerability to different complications quite dramatically. And so there is a need sometimes for different guidelines for smaller babies and lower gestation babies than higher gestation babies. And the exact thresholds to choose have largely been based in pragmatism and to some extent the evidence that's been collected. But it probably matters a whole lot less whether a baby is 31 plus 5 weeks gestation or 32 plus 2 weeks and 2 days gestation than a whole lot of other considerations. So these thresholds probably in both sets of guidelines are relative and need to take into account other variables as well. There's a promotion in both sets of guidelines of deferred cord clamping for at least 60 seconds as the preferred method of umbilical cord management, but the needs for some alternatives in situations where the baby can't wait for resuscitation or where deferred cord clamping may be unsuitable, such as when there's a much more depressed second twin on the way. Both sets of guidelines are increasingly emphasising supraglottic airway devices as a method of resuscitation, both in situations, potentially as an alternative to a face mask, where there's no one with the skills or capability to intubate, but also as an alternative to intubation in circumstances where intubation's failed. Video laryngoscopy is something that we're promoting based on evidence, particularly for those early in their years of experience. There was a big discussion about the European tradition for initial inflating breaths after birth, which has not been traditional in North America. And I think we would have to say that at the end of the day, it's a difference-based, and it's an evidence-free zone as to whether one is better than the other, but no reason not to stick with tradition. So quite a number of research gaps have been identified. The absolute optimal method of umbilical cord management for different subpopulations of babies. We did do a scoping review on the use, an ILCOR scoping review on the use of supraglottic airway devices during CPR, and based on indirect evidence have concluded that it's probably acceptable, but there probably really is a need for a proper study. Inflations versus positive pressure, just starting with positive pressure ventilation, the optimal interfaces to use, and the ideal oxygen concentration for starting resuscitation are still dilemmas. And I think that's us. Thank you very much.
So my name is Markus Krivars. I'm an intensivist working in Helsinki, Finland, and I present here the post-cardiac arrest care guidelines on behalf of the ERC, the SICM, and also the AHA. And we had a great debate present were Claudia Sandroni, Karen Hirsch, and John Rittenberger, and it was moderated by Ian. And I'll go through some of the differences and the similarities of the post-cardiac arrest care guidelines. And of course, first and foremost, post-cardiac arrest care is important. And we should make sure that in the absolute majority of cases, the patient needs care in the ICU, they need to go through the prognostication algorithm, and we should make sure that clinicians aren't overtly pessimistic and withdraw care in these patients too early, because there simply isn't data to support such practice. So some updates. Both guidelines now support the use of a whole body CT scan in order to look for treatable causes and also look for potential injuries like pneumothoraces or fractured ribs, which may influence post-cardiac arrest care. AHA also recommends ultrasound to look for tamponade and other things. Mechanical circulatory support like balloon pumps and ECMO and Impella, they should not be used routinely, but there may be select patients, perhaps the ones who are conscious and who have clear signs of a cardiogenic shock. Of course, this is complicated because most cardiac arrest patients have cardiogenic shock, but it's something that will disappear over the first 24 to 36 hours, and that's why routine use is not a good option. Both guidelines recommend treating seizures with your standard treatment for that. And also prognostication of a good outcome is very important in the cases where you need to do some form of surgery, coronary artery bypass grafting, or something else. Oxygen and blood pressure targets have been updated, and also, importantly, the value of rehabilitation, family support, and also support of the healthcare staff, the clinicians, which is something that AHA nicely addresses in the new guidelines. Here's some major differences. In terms of oxygenation, ERC recommends 94 to 98%, whereas the AHA 90 to 98%. Here the ERC focuses on the exact trial, whereas AHA sort of wants to take into account the overall evidence and the management in the intensive care unit, and recommend a slightly wider range for the oxygenation target. With regards to vasopressors and inotropes, ERC, because the most commonly used vasopressor is noradrenaline, and inotrope being dobutamine, we say that because there's no evidence to suggest that we should not do this, this is probably a good option, whereas AHA kind of says that there's no great evidence, so do what you usually do. So in essence, we are mostly saying the same thing. Temperature, if the patient is unconscious, ERC goes for treatment of fever only, whereas AHA recommends also in some patients striving for a lower temperature. Again, ERC, ESICM perhaps put more focus on the recent larger trials, which did not perhaps include all the types of cases, hypoxic cardiac arrests, drug overdoses, which is why the AHA wants to maintain the possibility of using hypothermia in the select cases. Then with regards to biomarkers, ERC recommends NSE or neuron-specific NLAs and a specific threshold. AHA recommends NSE and NFL, but at the moment they don't provide any specific threshold for where the outcome is perceived to be good or bad. Secondary prevention, ERC has some recommendations for that, whereas AHA does not at the present. Then with regards to blood pressure targets, ERC target the blood pressure, a systolic one, higher than 100 millimeters of mercury. AHA doesn't include a specific recommendation for this, but the recommendations for a mean arterial pressure are the same in the limits between 60 to 65, very much based on 4 randomized controls trials that failed to show any benefit if a higher target was used. Then using ultrasound to determine the cause of the arrest. Again, AHA recommends this, whereas ERC perhaps more to use a cardiac echo to look for cardiac abnormalities only, and not so much for as a mean to look for pneumothoraces or other things. Then treatment of myoclonus. Both in essence recommend these. ERC puts an emphasis on the EEG. We need to have an EEG, and of course AHA says the same thing. And if there's myoclonic movement and there's an abnormal EEG, even though the outcome may be poor in many of these patients, a treatment attempt is recommendable according to both guidelines. Then timing of prognostication. Of course, information about the perceived severity of the brain injury, collection of that data will start right away when the patient comes into the ICU. And 24 hours, you have your EEG, your CT scan, your biomarkers, but the decision should not be made before 72 hours unless the patient develops, for example, brain death. Then it's, of course, a clear situation. But if that doesn't happen, we should not do this too early. AHA, very similarly, but if a unit uses therapeutic hypothermia, we should delay it even a little bit further in order to make sure that the effect of sedation is not there to confound your prognostication. And I think that very much wraps it up. Thank you.
Thank you so much. I'm Dr. Rakesh Garg from New Delhi, India, and represent Indian Resuscitation Council Federation. We just had a lively presentation and quite intense discussion prior to this plenary session, where we have talked about system intervention, system of care, and ethics. When you talk about the chains of survival, both the guidelines has emphasis on all the core links. ERC emphasis was more on the low resource setting and preventive strategies, which was again an important aspect when we want to prevent the occurrence of the cardiac arrest. There was emphasis on survivorship in both the core links, both the chain of survival, which is again important because it is upcoming issue where we talk about the cardiac arrest survivors and their various issues. When we talk about the outside hospital cardiac arrest and we talk about training of the layperson, both the AHA and ERC has put emphasis on community response of the layperson CPR. Emphasis has been given that the early CPR by these people, which may be related to dispatcher-assisted or maybe telephone-assisted CPR, is an emphasis in both the guidelines. And both the AHA and ERC has emphasized that it's important that the community not only needs to be made aware, but they should be emphasized on teaching and training so that early CPR can be done in both the situations. They have also emphasis on the not only layperson CPR, but early activation of emergency medical services. And as we were just mentioning about the defibrillator aspect, ERC has mentioned very clearly that all ambulances should be well equipped with defibrillator and should be given as and when required. The another important feature by the ERC is incorporation of critical care teams. That's an important aspect which they emphasize to improve the quality of CPR and improve the outcome. On the other hand, AHA says that it can be beneficial to have ALS clinician for providing these type of care in the emergency medical services. But more or less, it mandates that these people need to be well trained. So there was some discussion about the availability of critical care physicians in the pre-hospital care at the EMS level, and that's where these differences was mentioned about in these guidelines of ERC and AHA. Also, these things about the termination of resuscitation. Again, an important aspect, how much they should be empowered for the termination of resuscitation when we are talking about more advancement. And they have mentioned that, ERC mentioned that it conditionally recommends EMS to implement TOR rules. On the other hand, EHA also mentioned that EMS should be prepared to perform termination of resuscitation outside the hospital. With regards to the dispatcher assisted or telephone assisted or using any modality for getting the layperson doing better CPR, both were unanimous in these aspects, and they mentioned that it should be very clear that the evidence was, the evidence was very clear, and they should be very well supported with the communication system so that they can be provided CPR at the earliest. The cardiac arrest center, another important addition to the guidelines, that these patients should be shifted not just to the nearest medical center, but those centers which are well equipped to provide care to these type of population after the cardiac arrest. So this inclusion of the cardiac arrest center by the group is an additional thing, and probably maybe the geographical differences or setting up these centers will be further emphasized by these guidelines. Regarding the ethics, again, a very important topic when we talk about the resuscitation, and they have nicely covered various aspects related to the shared decision making. They talked about the equitable health care, also the termination of resuscitation, patient participation in research. This is again important because we have been talking about the lack of evidence, the lack of research in various areas, that how they can be incorporated so that we have better evidences, better collection of data, and also about the organ donation. Now, the use of ethics, they have emphasized on many basic principles which are related to ethics. They emphasize upon the systems, advanced care planning, the bystanders and first responder, the research ethics, they talked about ethics education, and they talked about termination of research. All these important principles will make the research, make the education, make the provision much better. And this is for all the stakeholders who are included into the conduct of resuscitation at various aspects. So this is an important infographics that has come from these guidelines and will be very, very useful. With regards to the research, it's important, and they have touched upon this aspect also about the research ethics, and the informed consent and the regulatory pathways needs to be emphasized, that so that they can be safely and ethically included into the research participant during the resuscitation aspects. So this is in brief about the system of care and the ethical aspect by the group of AHA and ERC. Over to the Professor of Whitgriff.
My name is Tino Greif. I'm the current chair of the ILCOR Task Force Education Implementation Team. I present this on behalf of my co-chair, Adam Chang, and the leads of the guidelines for the ERC, it's Sabine Nabecker and Timothy Rath, and for AHA, it was Aaron Donegan and Katie Denti. We discussed a lot what we can see here, the importance of education and implementation in this formula of survival. Educational efficiency is still divided in structural design, how we train the population, how learning and the context of learning happens, and how we can improve our teaching staff. A lot of similarities were found also for the implementation part, so knowledge transfer and implementation on the individual level, team level, and system level. Not big surprise for the similarity. Half of the group of the ILCOR group are in the AHA writing group, the other half were in the ERC writing group. And the evidence is pretty the same. So what we looked at in instructional design are a different number and topics on modern didactic methods, which I not will read down, you see this over there, and also what's important for whom we are going to train, in which area people work, what are the resources they have for their training, what are the prevalences of training. So there's a huge difference in between laypersons and hospital healthcare provider training, which is often a very different level depending how often they have to do even CPR. Disparities, that's what I'm talking now, experience seems to be far more of an importance than, it's vice versa. Exposure is much more important than experience. So I might be very experienced in the theory of resuscitation because I was involved with the guidelines. My exposure to the real stuff is very, very low. So people who are doing this on a daily basis are for sure performing better than me, even if I know maybe more than them. So think on this, therefore training, and if people are not so often exposed, simulation comes in. So this is one issue. Then we have to train families, other significant others of high-risk populations. And then this is all the issue about mandatory CPR training and tailored training for the needs. Differences, obviously, you saw this all the time in the different way of how the guidelines are presented. So we in the ERC have always first a concise guidelines for the clinician, so really bullet points, what should you do, and afterwards comes the second part in the guidelines where the evidence-informed guidelines is, so the reason why we issued this recommendation. HA has another approach with this clear differentiation in the levels of evidence and the value of the recommendations. Knowledge gaps, we deferred a little bit because there was a decision also on the ILCOR level that we are going to investigate this after the process. So there will be, hopefully in a couple of months, a new publication where we will try to summarize the knowledge gaps, but not in the way that everybody tells us the 5 most important, and the number 1 is because we think this is the most important. We try to find out which gaps have an impact, economic-wise, stuff like this. So to trigger really the studies, the research, which changes survival. At the end, we had a nice discussion, what to change, what did we learn, what to change in the future, and what I think in the future, in 5 years, we need to start to change the way we bring across the guidelines. These endless lists of bullet points, these endless lists of a sentence, and then this language, which even in ILCOR we sometimes have troubles to understand. It's very hard to get across to the end users. And they are changing in 5 years. These youngsters, they don't read anymore these guidelines. They look at their phone, they want the answers in the moment when they need it. And therefore we have to transform the science we have to the new way and present this to all the people. That's all from our side. Thank you. And with this, the last group, very important. Now, what is going on these special circumstances?
Good afternoon. My name is Yingqi Ko from Taipei, Taiwan, an emergency physician, and it's my honor to be here. And before we go to the next PowerPoint, I would say that the special circumstances is a tough one because there are more than 30 topics are reviewed, and including more than 10 new topics. For the first time, the guidelines address topics including LVAD management, cardiac arrest in sports, cardiac arrest during microgravity, and obese patient, and high consequence respiratory pathogen, etc., along with more detailed recommendation for such as the traumatic cardiac arrest by ERC and poisoning related emergency by HA. And To sum up, the CPR remains the cornerstone of the resuscitation, though specific contexts within special circumstances should be modified to ensure safety and effectiveness. And to 2025, the ECOS or eCPR is now recognized as a viable option across more special scenarios when reversible causes exist. And here's the only slide that compares the similarity and the differences between the two guidelines. And I'm going to share with you the top 5 topics selected by the circumstances breakout session and with its takeaway for those who were not there. The first is the hyperkalemia. And the AHA highlights the uncertainty effectiveness of calcium and sodium bicarbonate use. I believe you know that. While ERC maintained recommendation for calcium use, but against the routine use of sodium bicarbonate in peri-arrest patients based on the latest evidence update. And the second one would be the left ventricular assist devices, LVADs, and both guidelines emphasize the early troubleshooting of the device and perfusion based during the decision making. But different in timing, especially ERC allows up to 2 minutes into troubleshooting to the LVAD before CPR for a single rescuer. And while HA promotes immediate chest compression when the perfusion is inadequate. And the third one, pregnancy, is always a hot topic in special circumstances. And both guidelines reinforce the 5 minutes resuscitative delivery. We have rephrased the term because this measure helps not only for the mother, but also for the baby. And beyond the 5 minutes is also effective. And also, the both guidelines emphasize the left uterine displacements, and the ERC further expand to include the 4Ps mnemonics for the reversible causes: preeclampsia, puerperal sepsis, placenta complication, and peripartum cardiomyopathy to guide our action. And the fourth one is the hypothermia. To sum up, cooling remains a key priority. The ice water immersion is safe and fast, with an optimal target cooling rate at least 0.15 degrees Celsius per minute, suggested by both guidelines. The last would be not the least, opioid-related cardiac arrest. ERC suggests that there's no sufficient existing evidence to recommend administration of an opioid antagonist, which is naloxone, for cardiac arrest caused by opioid poisoning, whereas the AHA considered giving naloxone during cardiac arrest without interrupting CPR if feasible. So I would say that not sufficient, but maybe reasonable. And AHA further sent the message that we should provide the survivors home with naloxone to break the cycle. And finally, to sum up the circumstances resuscitation, evidence is still evolving, but many areas still await for stronger data to support the recommendation. To be exactly, we have more than 4 PowerPoint pages to address the research gap. And particularly, there are lots of research gap in the field of resuscitation in special circumstances. Thank you.
All right, well, thank you. Let's have one more round of applause for all of our presenters. That was a great overview of the hot topics across all of the disciplines of resuscitation. And I think we're going to turn it over to Jeanette Previty and Gavin Perkins for our closing remarks.
Thank you, Bob. Hello again. So our closing remarks really center around gratitude. First, I want to thank everyone who's attended today, live and online. It's been a great program for me, and I hope that you all found it just as inspiring and inspirational, and you'll take it back to your facilities so that we can all save more lives for everyone everywhere. Okay, next, sorry, Jalen. So I wanted to thank all the people in the writing groups for AHA. I would love to give all your names thanks, but it's just too many people. But you can appreciate the amount of expertise and time and dedication. So this is page 1 for some of our writing groups, and page 2 will follow. And also want to thank our our staff and consultants that helped make this program successful and helped made the guideline process successful. Our science and health advisors, support staff, science leadership and oversight, senior science editors and librarians. I also want to thank Camilla Sasson and Jalen Wright for making this program run smoothly today. Not a small feat, so thank you. And I believe that is going to be my cue to turn this over to Gavin Perkins, my esteemed colleague and the Director of Science and Research for ERC.
Thanks very much, Jeanette, for the kind introduction, and thank you to the organisers of this fantastic session for the opportunity to address you in the closing session. I think it really, having been in the different rooms, having participated in this session, I think it really shows how much has been achieved in bringing these guidelines together. On behalf of the European Resuscitation Council, there's a huge amount of thanks that is due to people. Listed here are the members of the writing group. These are the colleagues that have taken the science, the education and the implementation lessons from ILCOR and translated them into tangible guidelines in order to help save lives and to help the European Resuscitation Council achieve its mission of saving more lives by making resuscitation available to all. We continue with neonatal, special circumstances, post-resuscitation care, education, ethics, first aid, huge contributions from all. But of course, the guidelines aren't possible simply from the work of the scientists, the researchers, the patients and the public that have contributed. It's reliant on the huge amount of support from the staff in the ERC office that have assisted us, from the consultants that have helped us with the graphic designs and the preparation of our materials for the public, and also to our patient and public collaborators that have really helped us make sure that we frame our guidelines that are going to be fit for purpose. I think if we all take one thing away from the session today and the guidelines, is that the implementation of these guidelines, be they the AHA guidelines or the ERC guidelines, implementation across our communities will save many thousands of lives. And let's that be the message that we leave today with. So a huge congratulations to everybody that has been involved, and a huge thank you. For colleagues that have pre-registered, there is a celebration event coming up tonight. The details are up on the screen there. I understand it's about a 5-minute walk away from the meeting room here. So if people want to make their way along there, we look forward to continuing the celebration of the guidelines with you. A special request for people that have been involved as a moderator or a presenter today, that if they can come up to the front, then the organisations would like to take a photo as a record of the event. So thank you all very much for your contributions.